Right.
Okay, everyone. We should be live now. I'm just going to ask if you can help us out in the chat. Let us know if you can see and hear us okay. Thank you to all the attendees. Let's see here we have. Hi, everyone. Welcome. If you can see us and hear us all right, you want to give us just an okay thumbs up in the chat, and then we'll start our presentation. We can hear you. No volume. Okay. It looks like we have one can hear, one can't. Sylvia, I'm going to ask you actually to click the Use Zoom app, little blue link that's underneath the presentation window. That'll take you to a Zoom app where you can hear it. If anybody else is having the same problem for either video or audio, I suggest the same. Otherwise, we're going to go ahead and get started. But again, if you're having any kind of, it looks like we have some tech support going on in the chat. Thank you, kind folks. So my name is Chris Chapman. I'm the Communications Director with the Alzheimer's Association New Mexico Chapter. Again, welcome everyone. I am privileged to introduce a good partner of ours and a good friend of mine. We're lucky to have him here to present today, as he also presented yesterday. Without further ado, is Chris McCaffrey, who is an administrator with the Northridge Alzheimer's Specialty Care Center. Special Care Center. The topic for today is my loved one okay? What long-term care looks like during the COVID-19 pandemic. And I'll just also add, if you have any questions during the presentation, please post them in the chat. And about 45 minutes in, we'll have a quick Q&A. So without any more of me talking, Chris McCaffrey.
Hello, everybody. Welcome. Thank you for being here on a Saturday. Like Chris said, I am Chris McCaffrey. I cannot see any of you, obviously, but my guess is that I probably know a few of you, or a few of you probably know me, or vice versa. So welcome to all of you I know, and welcome to all of you I don't. I'm glad that you're here. I am currently the administrator for an assisted living facility here in Albuquerque, Northridge Alzheimer's Special Care Center. Our entire population is comprised of folks with Alzheimer's or other kinds of dementia. And I'm thrilled to be there, and I'm also thrilled to be working with the Alzheimer's Association again in this capacity. So that's my story. I'm going to switch us over to the slideshow, and I'll still be up in the corner, but you'll primarily be seeing the slides at this point as I share. All right. So a little bit about my background before we jump in full bore. I've only been at Northridge for about 2.5 months. In my previous experiences, I have worked in mental health. I have worked in senior care. I was, in fact, the program director at the Alzheimer's Association for many years. So I do have a background in dementia. In particular, providing programming and working with family caregivers, facilitating support groups, conducting educational programs, coordinating respite care, all different kinds of things like that. And then on and off, like I said, working in the mental health sphere. So I think that I bring a pretty diverse understanding to this topic, which is a huge one. I just want to, I can answer the question, is my loved one okay, pretty simply. I could say yes, and we can all be done today. But of course, it's not that simple. There's a lot of nuance there, and everybody's definition of okay is going to be a little different. So my objective today is to have a conversation about understanding what's going on inside of facilities, who's making decisions about these restrictions, why those decisions are being made, and for all of you to have a really clear understanding of what that looks like and why, as well as what you can do to help yourselves feel okay about everything that's going on, and in particular the restrictions. Those of you who know me will know that I have a strong affinity for the family caregiver. And my belief is that our job at Northridge, as well as the job of everybody who works in long-term care, it isn't just taking care of your loved one who has dementia. You are our clients as well. And so your experience, what you're going through, what you're feeling, and what you're needing, all of those things have to be priorities as well. And so part of what I'm hoping to get to today is, one, to validate that for you, also to empower you to have some tools to have your own needs met in this role, and to differentiate the difference, right? Meeting your needs is important, but your needs are different than your loved ones. And so in order for the needs to be met, we have to be careful not to conflate the two. So I'm hoping that in addition to giving you information about what's happening right now and tools for what you can do about it, that at the end of it, we have sort of what I call a dialectical point of view, where we see both sides of that equation, and that nobody is vilified. The goal here isn't to point fingers or lay blame for the situation we find ourselves in at anybody's doorstep, but really to be able to see things from all perspectives. So I hope that that is what you were wanting to get today. And if not, send a chat or a comment to Chris, and at the end, I will try to address that as best I can if it doesn't fit in the context of what I've just laid out, okay? All right, let's get started. So I think the first thing is what we have to talk about is what is going on. So what we know, what's going on in these facilities right now, is that there are a ton of restrictions, right? We have had restrictions on visits, on clients leaving, on who gets to come into the facility, who gets to visit, what do visitations look like, what gets brought into the facility, right? What kinds of foods or snacks can you bring in? And it affects everything from that to where the staff members get to work, what your loved ones' daily lives look like inside the facility, right? It affects all different kinds of things. So we have to talk about all of that and work within that frame as we decide what you can do about it going forward. So who gets to decide what's happening in there right now? Well, there's multiple players, right? There's a lot of people imposing guidance on facilities, on you as family members, on what care looks like. So we've got state departments, the Department of Health, as well as other state departments that I'll talk about in a little bit, who are imposing guidance on what can happen and what shouldn't happen in the midst of this pandemic in order to keep everybody safe. In addition to that, the facilities themselves will impose new policies and procedures in response to situations like this. And in some instances, as in the case of my facility, we are corporately owned, which means the company that owns Northridge owns many other facilities as well. So they impose guidance not just at our local level, but they have to look at all the facilities nationwide and make decisions about what's going to serve those populations and protect their interests as a corporation all around the country. And we'll drill down into that a little more going forward. Additionally, when your loved ones are in a long-term care facility, it's not uncommon for them to receive services from hospice companies, home health agencies, different things like that, who in turn will have their own policies and procedures dictating what they're going to do and what they're not going to do during times like this. So there's a lot of different players involved in making decisions about what care is going to look like right now. All right, so let's start with the first one because it's probably the most impactful body making decisions about all of us, frankly, but in particular your loved ones in care right now. And that's going to be the state of New Mexico's government. We have a few different players even under that umbrella. The one I think that we hear about the most is the New Mexico Department of Health. They impose guidances across the board, everywhere, not just in long-term care, not just in assisted living facilities like mine or nursing homes, but every aspect. So when you hear about restaurant closures and different things like that, those are typically being driven by the New Mexico Department of Health. They set the regulations for compliance of long-term care facilities and nursing home. And really their job, what they're tasked with, their primary concern is stopping or slowing the spread of diseases and epidemiology, right? So really their main concern is how do we get a handle on this virus and keep it from spreading in such a way that it paralyzes or negatively affects hospitalization and the resources we have as a state to treat people and take care of people. So you've all heard about the flattening the curve, right? Bringing that curve down. The idea is that, yes, at some point, many people will get the virus, but the idea is that if the number of people who get it can be spread out over a longer period of time, allowing some people to come in and receive treatment and then move out as other new people move in, instead of all of us coming into the hospital at the same time, hospitals that aren't equipped to treat that many people in a way that we would need to be treated. That's sort of their main concern, right? How do we address the spread of it? How do we keep it from getting out of control and minimize the number of people who either get it or are in other ways affected by it? And so to that end, they impose a lot of guidance and a lot of restrictions. So when we talk about visits being restricted, the number of people being allowed into a facility, restaurants operating at only 50% capacity, all of the things you hear like that are typically driven by the Department of Health. But they aren't the only ones. You also have in New Mexico, we have Aging and Long-Term Services Department. Their primary concern is the senior population, right? And so they are looking at guidances and data collection around, do facilities have enough personal protection equipment? Do they have enough staffing? Are they getting enough masks and gloves and gowns and things like this? They're concerned with, is the aging population receiving the services that they should? The Ombudsman's office that you may have heard of before operates under the Aging and Long-Term Services Department. So the Ombudsman's office makes sure that that folks in long-term treatment are being treated with dignity and respect, that their rights are being respected, that their lives are still maintaining a level of independence commensurate with their ability to make decisions. All of that kind of stuff falls under the Ombudsman's office, which in turn falls under Aging and Long-Term Services. So they're also setting guidances around things like if facilities cannot have in-person visits, what alternatives are being provided. And as a facility, I'm required, as the head of this facility, I'm required to provide documentation showing all of the other efforts that are being made to accommodate visitation and things like that, while in-person visits can't take place, okay? Additional to that, in New Mexico, we also have the Environment Department, which is responsible for all the rapid response testing in the workplace and providing guidance on testing for businesses all around New Mexico. So when you hear about things like, for example, in our state or in our facility, we're required to randomly screen for COVID and provide testing for COVID on 25% of our staff and 25% of our residents every week. So a lot of that is being driven by the Environment Department, sort of giving guidance on what appropriate testing should look like, where that testing goes, et cetera. So what you start to see is there's a pretty there's a lot of cooks in that kitchen. And sometimes their goals overlap, right? Sometimes it's a Venn diagram and there's definitely some commonalities, and sometimes not. Sometimes what they are looking for can be at odds even with each other within the department, okay? So the other folks making decisions, of course, are the facilities themselves. And I think probably the things that have to be talked about here, there's going to be a lot of commonality here, but particularly as you move into more corporate ownership, what you're going to see is that many of these places own more than one facility. And even a facility that has as its highest priority the dignity and quality of care for its clients, they are still a business. And so they do err on the conservative side when it comes to things like avoiding litigation and things like that. There's a saying that says, every piece of paper that you've ever signed was once a lawsuit. So when you go to buy a house or buy a car, every one of those pieces of paper that they make you initial and sign is because at some point somebody did something that they didn't want to. They challenged something or took them to court over some issue. And so it isn't uncommon for sometimes the policies and procedures of an actual organization to exceed the requirements of the state. And I'll give you an example. This isn't really a COVID example, but at Northridge, our staffing ratio is really high. It's higher than what is dictated by the regulations of the state of New Mexico. So the licensing regulations for New Mexico, I think, are 1 to 20, one staff for every 20 residents. And ours are much higher than that. We typically operate around 1 to 10 or 1 to 8. So in some situations, the facility, the corporate ownership will dictate or provide guidance that in many ways is restrictive as well. And again, yes, we do have to acknowledge that sometimes that has to do with fear of litigation, but not always. A lot of times it's really around issues of safety and standards for keeping everybody healthy and safe in that. I saw that somebody did a hand raise. I don't know how we're working that. I'm going to defer to Chris Chapman to let him decide.
Hi, thank you, Chris. Just to address attendees, go ahead and put your questions into the chat fields, and then we'll get to them at the end of the 45 minutes, which I think is going to be around 2:30. So
yeah, we'll leave plenty of time for that.
And if you feel like it's something that you need to elaborate more, just go ahead and put it in the chat, and we'll just ask Chris to please continue.
Okay. All right. So we've got the different departments in state government driving decisions and imposing guidance, and we also have facilities themselves doing that. And then, of course, like I mentioned, we have other outside agencies that often provide support, also being driven by their own policies and procedures around what they are willing to do and not willing to do, often for the same reasons, right? They're interested in avoiding litigation, as well as keeping everybody, including their hospice staff, safe. I do want to take just a little bit of a detour here, not too much because I'm not an expert here, but I do know I did, for those of you who are unaware, in preparation for this presentation, I did some research with support group leaders from the Alzheimer's Association's dementia support groups. And they gave me feedback about a lot of questions and concerns that come up in their groups that they felt like people would want more information on. And then just some family caregivers I spoke with too. And a common theme that came up was folks not really understanding what hospice is or what it does. So I'm going to take a short detour and just explain that, a very 30,000 foot view, again, because I'm not an expert and there are a lot of people, probably some speaking today, who are experts on hospice, and I would definitely defer to them. But I do want to talk a little bit about what hospice is and what it isn't, because I think understanding that helps people understand, some of what we're looking at right now in terms of restriction. So hospice is a service and not a place, okay? It's a kind of care that is designed to focus specifically on the quality of life for people as well as their loved ones and family and caregivers. Typically, they're experiencing an advanced life-limiting disease, okay? The goal is to provide compassionate care in the last phases of an incurable disease, allowing for as full and as comfortable a life as possible. So even going with that definition, there's a lot to unpack there, right? As full and comfortable a life as possible. So all of you, I'm assuming if you're here, have a pretty good understanding of what dementia does, particularly in the last stages. So a full life for somebody who has advanced Alzheimer's disease is going to look different than a full life for somebody who has a different disease, perhaps, right? We tend to see fulfillment and quality of life. It's hard for us to imagine that when we see our loved ones struggling to even form sentences or conjure up memories, when their cognitive decline is so advanced that they don't seem there. It's hard for us to imagine that they are having any kind of full life. And the reality is that they can, right? There are a lot of programs. We at Northridge do something called Meaningful Moments. I know that the Alzheimer's Association has caregiver classes that really emphasize being present and finding gratifying and fulfilling activities and interactions for people, even in the latest stages of the disease. So I think it's important for us who do not have dementia to really be able to get in touch with the fact that yes, even somebody in the later stages can have a certain degree of fulfillment, right? We have to agree that it's within the stages, within the context of the stages they're in of their disease. So that's what hospice is designed to do, and that's what it's designed to perform. The average duration of somebody being in hospice is about 67 days. So on average, some people are on it a much shorter period of time. Some people stay on hospice for a much longer period of time. Generally speaking, it should be begun when the expectation is that somebody is within 6 months or less of passing, right? That they're very much in the last stages. But that doesn't mean that they're going to pass, right? That's sort of one of the things that's difficult about it is people often feel like they are giving up if they agree to allow their loved one to go on hospice, that somehow they're giving up. And that's really not the case. People come on and off hospice really depending on what's going on. The idea of putting somebody on hospice is to, again, increase their quality of life. Because what hospice does is it treats the person and the symptoms as opposed to the disease, right? And so there's not a cure for dementia. There's not a cure for Alzheimer's disease. So somebody being on hospice, it would really be about addressing issues associated, symptoms associated with the disease to help them feel more comfortable and be more safe. Hospice is also very family-centered. So a lot of what hospice provides are things like case management and family meetings, bereavement counseling for family members, as well as the hands-on kinds of things for the client, like medications, showering aids, nursing, durable medical equipment, these kinds of things. So the service is really all-encompassing, and the design of it, the intention of it, is to provide as high quality of life and comfort as possible for the client, okay? So keeping that in mind, there's a lot that goes into hospice, and I'll talk, when I talk a little further in about some of the restrictions that are being imposed right now, I just want us to all be on the same page about what hospice is when we talk about some of the ways it's being restricted, okay? So it's very broad. There's a lot of things that hospice can do. Additionally to that, we also have home health agencies that will sometimes come into a facility and provide things like physical therapy or occupational therapy or speech therapy, right? This typically, depending on what stage a person is in the progression of their disease, some of these things are not necessarily considered priorities because the nature of dementia, of course, is that it affects short-term memory. And a lot of these therapies like physical therapy and occupational therapy are, they're hinged on being taught new skills. And of course, the issue with that is that if I have difficulty remembering, if I can't remember the skill I was taught yesterday, today, it's probably not going to be terribly effective. So that's something to keep in mind as we go forward. So like I said, a lot of different people making decisions that have brought us to right now, which is what I want to talk about, what long-term care looks like in a facility now. So currently, at least for assisted living, what's being imposed on us through the Department of Health guidance in particular are no indoor visits. People are not allowed into facilities because the Department of Health recognizes that these are self-contained, sealed little bubbles, if you will. The only way COVID is going to get into that facility is somebody bringing it from the outside in. It's not just going to crop up inside there. And so to that end, they really want to reduce the number of people coming into the facility who could potentially bring it in. So no indoor visitors are allowed. All visits currently are being conducted at what we call window visits. That looks different at each facility. At our facility, we have headsets that are remotely wired to each other. So we can bring our folks up to the window, and their loved ones can be outside with a headset, and they can talk through the window. We also are doing a lot of video chat, Zoom, FaceTime, different things like that. The effectiveness of those varies. I'll talk a little more about that further in, but that is something that we're offering. Depending on where a county is, again, the Department of Health has sort of looked at the percentage of COVID cases in each county, and we have designations like green, yellow, and red. Red means really high, obviously, and green is lower. Depending on where a county falls, they may be allowed to have outdoor visits. They have to be divided with a plexiglass barrier and separated by at least 6 feet. Ideally, they want people wearing masks during those visits. So there's a lot that goes into that. So much so that a lot of the families that I work with seem to prefer the window visit. It just kind of depends. Not everybody, but some people do. And so the only other people allowed in would be medically essential providers. So that takes us back to the question of hospice, right? Some of you may have heard hospice workers not being allowed into a facility. But what the designation is because hospice provides so many things, what they have to look at is which of those aspects of hospice can be provided remotely and which ones are considered medically essential, right? And so case management, for example, is not considered medically essential because it can be provided both to the client and to the families remotely, right? That can all be done with video. They are not considering shower aids medically necessary because the staff in the facility can assist with showering. And so there are certain aspects of hospice where the guidance is those folks are not allowed in. But nurses, hospice physicians, the delivery of durable medical equipment, a lot of these things are still occurring. Okay, so hospice nurses are allowed to come into facilities. If the hospice company itself determines that, no, we do not want our nurses going into a particular facility, that would be their call, but not the facilities, right? So again, you start to see how this can be, can start to get somewhat muddied up depending on who's making the decisions and why. The other thing to think about right now in terms of visits is that the Department of Health is allowing what they call compassionate care visits. So if somebody is within, I believe it's 2 weeks of passing. If a doctor has said, you know, this person has about 2 weeks to live, they will allow indoor visits called under the compassionate care aspect. That's, again, it's going to be limited. We really have to implement certain protocols to get the visitor to the room where the client is as quickly and safely as possible to minimize contamination. So they can't walk through the entire building to get to where their loved one is. We have to do take different steps to make that as safe as possible. And they do dictate the number of visitors and how frequently they are allowed to visit. So typically for the compassionate care visits, it's one visitor per hour over the course of a day, with no more than, I think, 4 visitors in a day. So it can rotate, and we have had people there for longer periods of time. But in terms of actually in the room, it's typically one person at a time. Of course, everybody is quarantined. So when we have new people coming into the facility, we're required to have them quarantined for 14 days. This is not isolative. They are not by themselves, but they have to be quarantined in a room with only staff or outside visits at the window. Again, not brought into the general population until we're sure that they're symptom-free. The other thing it looks like, as I mentioned earlier, we're required to complete weekly testing. Depending on how things are going, it's usually a random 25% of staff and 25% of residents each week. But if COVID shows up in the facility or the county in which the facility resides moves into the red zone, we sometimes have to move up to 100% testing every week. So for example, if we have a case of COVID at a facility, immediately we have to begin 100% testing of everybody, staff and residents, each week for at least 28 days until there's no evidence of COVID in the facility. It also has impacted things like what life looks like inside the community. So for example, communal dining has gone away. We can have no more than 2 residents socially distanced at a table. So we can have people in the same dining room, but all the tables are distanced, like what you would see at a restaurant now. Again, to sort of minimize the spread if it were to occur. All of our activity groups are limited to no more than 5 residents, again, socially distanced, so we can't have the larger group activities that we used to. All of the living areas in the facilities now also have to be social distanced. So if you had previously visited a facility where your loved one lived and you went in there today, you would see it looks pretty different. All the furniture is spread apart. The living areas look very different in order to accommodate that. You also see staff in their personal protection equipment we have to wear masks the entire time. If things change, if COVID shows up, we may have to wear different masks or even full PPE. We have to wear face shields when we're assisting folks who need help with feeding or eating, a lot of things like that. And then again, some of the ancillary services that they consider non-essential, like the hair salons, which are a really nice sort of treat for our residents, those are no longer open. We're not allowed to have those kinds of services. So what I do want to do, I of course want to validate that do these restrictions have an impact on your loved one? Of course, absolutely, right? Some of the things that we know are showing up in populations as a result of these restrictions, without the ability to see all of you as regularly as they were, without being able to have the physical touch of all of you like they were before. They're obviously experiencing much less interactive stimulation with you. And that can sort of lead to a disanchoring of their current reality, right? All of you provide an anchoring to their memories, at least while they're progressing through the disease. At some point that doesn't happen either, but early on it is. It's something that they rely upon to sort of stay anchored to who you guys are. It can also sort of appear to slow down the cognitive decline. I want to spend a second on that because I have always, even when I was at the association, I always struggle with the phrase slowing the disease down, right? Or slowing the decline down. Because I think that sometimes that can create maybe a false sense of what's happening, that somehow certain things keep the disease from progressing. And that isn't necessarily accurate, I don't believe. The disease progresses. It is a progressive neurodegenerative disease, which means it's doing what it does regardless, right? Because we don't have a cure for it. But certain stimulation, certain activities or meaningful interaction, even some of the medications early on, what they can do is they allow a person to function at their highest given where they are in the progression of the disease. And so if I'm functioning at full capacity, whatever my capacity is, if I'm sort of at my peak capacity, I present better, right? I appear more present, I appear more cognitively capable, I appear less confused, right? And so it allows me to perform better for longer, but it isn't slowing the disease down. And so I feel compelled to say that. I think it is important to understand that interaction and social engagement allows people to function at a higher level for a longer period of time, but it doesn't slow down the progression of the disease. And that may be a matter of semantics, but I think if we agree to be on the same page about that definition, especially as we talk about strategies for all of you later on, I think that that's going to be an important distinction, okay? But the bottom line is, do the restrictions, does the lack of ability to visit have an impact on your loved ones? Of course, right? There's no way that we can deny that. And it's a detrimental one, right? There's no two ways around that. So why would we do all this if that's the case? If we know that cutting down on socialization and in particular their ability to visit with you, why would anybody impose that on a population that so desperately needs it? Well, I think there's a few things that we have to keep in mind. So what we know right now is that the population of long-term care facilities comprises only about 6% of COVID cases in the United States. In other words, if they look at every COVID case in the country, only a sliver, only about 6% are occurring in long-term care facilities like assisted living and nursing home. The kicker, though, is that about 38% of all the deaths in the country are linked to long-term care facilities, okay? So even though only a small percentage of overall cases is in that population, a big chunk, over a third, come from long-term care and associations with that. So both of these, both the number of cases as well as the number of deaths are occurring in that population. And those numbers include the staff, right? So again, what you're talking about is people who come and go from the facility being at higher risk as well. And so I think it's important to talk about this. Infected people linked to nursing homes also die at a higher rate than the general population. The median case fatality rate, in other words, the number of deaths divided by the number of cases at facilities with reliable data is 16%, which is of course significantly higher than the 3% case fatality rate nationwide. So when you look at all these organizations I've been talking about making all these really restrictive decisions, what we have to look at is it's a hotbed, right? And the potential for problem in these facilities is so high. And so people making these decisions, they really are erring on the side of how do we keep your loved ones as safe as possible? Because 3%, right? That may not sound like a big deal. And I know that there's different opinions, and people talk a lot about, this not being any worse than the flu. But let's look at this for a minute. The population of the United States is about 328.2 million. Okay, it's a big number. 3% seems so small. Well, 3% of 328 million is 9.9 million, right? So even if only 3% of the folks who contract this disease in the US died, we'd still be looking at over 9 million people. Okay, that's no longer a small number. So I think it's important to keep that in mind. And that's at 3%. In our facilities, in the long-term care industry, that number jumps up to 16%. Okay, that's a lot of folks. And so the restrictions that are being imposed, they really are being imposed with that in mind. Like how do we keep it from getting into these populations? Because when it does, it's much, much worse than it looks anywhere else. Okay. So what do we do for all of you? How do we help you guys deal with that? Because I do think that, again, like I said right at the beginning, your experience of all this is just as important, right? For what you're going through, the grieving that you're doing, the loss that you're experiencing at not being able to interact with your loved ones in the way that you have grown used to is a real thing. I cannot overemphasize that. I can't validate that enough. And it has to be addressed, right? What you're feeling, what your needs are, that has to be looked at, and it has to be addressed as a problem that needs to be solved, okay? And what your experience is, what you're going through isn't necessarily the same experience that your loved one is having in the facility. And so I want to talk about ways that we can move to something called a dialectical perspective. And dialectical means basically that two truths can exist simultaneously. Two things can be true at the same time. It's a way of moving away from black and white thinking and being able to validate a different perspective, okay? Depending on where you sit, you're going to have your own perspective, but it doesn't mean it's the only truth. There are other perspectives as well. So I want to talk a little bit about ways to move in that direction.
Chris, just a quick reminder, we are nearing the 2:30 mark.
Okay, so I will, yes we are. All right, so let me go through some of these. I think some of this will address some of the questions that you guys have. I want to talk about what and how skills. So what is it that might help you feel more okay with what's going on, and how do you do that? So the what skills, I think the what that has to happen is we all have to manage our expectations, right? And that's why I spent so much time sort of framing all this and talking about how we got to where we are today. Because I think if we understand what, again, why these decisions have been made, the statistics that they have and that drove the decisions, it allows us to manage what our expectations are. So managing expectations around things like, yes, we can accommodate by doing FaceTime visits on the telephone, right? But if your expectation as a loved one is that FaceTime visit, that your loved one is going to perk up and respond to that in a very specific way, you may have an unrealistic expectation that's sort of setting you up to be sad or disappointed, right? Because when I say to somebody with dementia, oh, look, you have a phone call, what's happening for them? Well, for them, a phone call means an old rotary dial phone that you put up to your ear and listen to somebody talk. Well, I put this iPhone in front of them with a screen. That's not telephone for them. So right out of the gate, I'm sort of setting them up to be confused because they're sort of looking at this thing going, well, it looks like a TV show, or right? Or if I set them up on Zoom, they're thinking that they're watching television, right? So they're confused right off the bat. So managing expectations around the fact that sometimes that will work and sometimes it won't. I think being able to communicate effectively with the staff at your facilities. right? Part of that is going to be checking the facts. So if I, oh, hold on one second. Okay, right there, something happened, right? All of you saw me disappear off the screen, and you didn't have any information about why that happened. Some of you probably thought maybe his doorbell rang, maybe he dropped something on the floor, maybe he had to go to the bathroom really bad, right? You didn't have the information that you needed to understand why what happened. And so you filled in the blanks. But just then, your filling in of the blanks was incorrect. And so often as human beings, when we don't have information, when there's gaps, we fill in the blanks with our own story. And unfortunately, that's not always accurate. So part of effective communication, particularly with the facilities that your loved ones are in, if you're not getting communicated with, if you're not getting information from the facility, it's really important that you check out the facts yourself as opposed to trying to fill in the blanks. In a perfect world, you are getting all the information that you can get. You're being over communicated with regularly, but that doesn't always happen. And so for you to be effective, it's important that you feel like you can ask the questions and fill in the blanks yourself. It's important for you to practice self-care and find new tools for your toolbox. Practicing radical acceptance, which is the true understanding that so much of what's happening right now is out of our control. And so to sort of rail against what's happening, it only increases your suffering because there's a lot of what's happening right now that we can't change. So how do we do all these things? How do we do all the things that are listed under the what skills? Well, I think one of the main things is to learn about dementia. I think that really helps to help you manage your expectations of your loved ones, of yourselves, of the facility who is providing care to your loved one. All the expectations we have can be much more effective and realistic if we understand them in the context of what dementia is and what it does. You could do that, of course, being here today is a big part of that. Attending the caregiver classes that are offered by the Alzheimer's Association or the support groups, right? Support groups are a great way to not only learn new information, but it's a great way to practice self-care. Familiarize yourself with all the state bodies I've been talking about and the guidances they provide. Those are all available online. I'm going to show you those here at the end. And then practicing what I call the STRONG skills. And STRONG is just an acronym around self-care. So the S stands for make sure you're getting enough sleep. The T is for taking your medications as prescribed or treating illness symptoms, right? It's basically around not minimizing your own health, taking care of yourself. The R is for resisting any sort of reliance on drugs or alcohol because I'm not going to dictate what people do, and I certainly don't have a problem with people doing what they need to do around that, but having the awareness that we are more susceptible to vulnerabilities when we're compromised, and being able to monitor that for ourselves, I think is an important piece. Once a day is the O. Once a day, practicing something that makes you feel competent or confident, or practice mastery. Do something that you're good at, something that makes you feel good and in control, because there's so much happening right now that's out of our control. The N is for nutrition, right? Making sure that you are not overeating, undereating, eating in a balanced way. And the G is for get exercise. All of this may sound like common sense kind of stuff. It might even sound trite. And yet my guess is that a lot of us aren't practicing these things right now. And it really can make a difference, because if I reduce my vulnerabilities, I'm much more able to do the things on the what column. I'm much more able to slow down and check the facts. I'm much more able to emotionally, radically accept what's happening right now. I'm much more able to find new tools, all of those things, if I'm practicing self-care. So it might sound trite, but it's important. The last thing I just want to leave you with before we start questions, and all of this will be made available to you, but there's some great resources and some great tools for all of you to sort of put in your toolbox to better understand where things are now and make decisions about how you take care of yourself and what you expect for your loved ones. Of course, the Department of Health, all the things that I've talked about in terms of their guidances and regulations, if you want a better understanding of that, there's their website. Same thing for aging and long-term services. I'm guessing if you're here, you probably have all the information for contacting the Alzheimer's Association, but again, a fantastic resource. If you have more questions about hospice, this website is fantastic. It describes all the things that are available and can really help give you a clearer understanding of that. And then the New Mexico Environment Department for issues around testing and the guidance that they provide. So with that, why don't we go ahead and see, I'm guessing that there are questions, so why don't we move into that?
Thank you very much, Chris, for that very informative, timely, and important presentation for those of us who do have loved ones in long-term care during these very challenging times. So appreciate that. Thank you.
Yeah.
One of our first questions, I'm going to try to go ahead and frame it under the, given the topic, completely under COVID-19, but I'll read it verbatim.
Okay.
Concerned about personal care not being given to those in assisted living centers, families trying to figure out how to provide hair and nails grooming, concerns about bruises and lack of following care plans, understand about COVID, but once outside folks can get in, real concerns about lack of services offered when needed, having to push in little communication to families. Is that something that you can address under the topic umbrella?
Well, I can speak to what I know about our facility. So when we are not under the restrictions that we are now, again, like I mentioned, hospice, people who are prescribed hospice have access to a lot of other kinds of support, not the least of which would be shower aides under hospice, folks who come in and take care of a lot of the tasks that the caregivers are now having to provide. That said, the caregivers are providing those, the showering, the nail clipping, nail painting. I even have 2 staff right now who are cutting hair since we can no longer have the salon. So a lot of that kind of stuff is continuing to be provided. Obviously, the amount of resources is smaller because we don't have staff, hospice staff or other folks coming in to do some of that. And we don't have all of you coming in to do it, right? I know that that was something that was really positive at my facility before, was family members could come in, and not only was it almost like a support because they were providing manicures or things like that, but it was also a way of connecting and interacting in a really meaningful way with the loved one. So it was kind of killing 2 birds with 1 stone. So to that end, it would not, I'm not going to say that somebody's nails might need to be trimmed, or somebody's, might have come to a window visit right from lunch and we didn't have time to change them into a clean shirt. Those things kind of, yeah, they're inevitably going to happen. But that said, if you are feeling like their care is being neglected or just not taken seriously, I think that falls to what I was talking about before, which is communicating effectively, being able to get that question answered to your satisfaction. That doesn't mean that you have to be belligerent or confrontational, but I do think that you are entitled to have that question answered in a way that makes you feel like, okay, I got the answer. It won't necessarily mean that you like the answer. For example, if you came to me and I had to say, we were working with 3 less staff last night than we normally do, and when I investigated, I found out that your mom was brought to the window visit wearing dirty clothes because we didn't have time to change her before the visit. You probably would not like that answer, right? Knowing that we're working with less staff and that getting her changed wasn't a priority, but at least you would have the information and it would be accurate, and you're entitled to that accurate information from the folks who are providing that care. Again, because your needs are important too, right? Your need to have that information is valid, and you deserve it. And so I think you need to be able to ask for that. I hope I answered that.
I think that's pretty good. Just to be maybe even a little bit more specific about what to do. Is the recommendation for the families to share the concern with the long-term care community first?
Yeah, I think so. I think you can start with, if there's a caregiver or a nurse available. Again, that a lot of your concerns may not be immediately addressed by that, for example, because they wouldn't have the information right on the spot. But if you felt like you weren't getting answers to those questions, then you would just ask to talk to the administrator or call or email later, because I know myself and I'm confident saying that other administrators want to know that and would want to investigate why that happened and get you the information that you're asking for. So again, managing your expectations around how quickly you'll get the information, but definitely you should have the expectation that you're entitled to it, because you are.
Okay, very good. So this one is, forgive me for always trying to reframe these, but
No, it's okay.
this might be too general, but I mean, given all the challenges of professional care for someone during these times, during the pandemic, the question literally is, what is your opinion of a loved one being admitted into a facility during COVID-19 anyway? I mean, being that you do have the option to care for them at home, maybe it's getting very challenging, but given the pandemic, how do you think families should weigh that decision now that the times are different?
I think that you would weigh it the same way that you always would. I think that and when I worked at the association, I used to say this all the time. There's as many answers to that question as there are people with dementia and caregivers. I might know somebody who has decided to keep their loved one at home, and they provide all that care. They do all that stuff. They get the medications, they coordinate doctor's visits, they transport, they change adult diapers, they provide care, they provide meaningful activities, all of the things that we would want. And they do that, and they do it just fine. That doesn't mean that that's the standard for every family caregiver. There's a million different reasons why a loved one would not be able to provide that kind of care. And they shouldn't be judged for that or held to some standard that doesn't have any meaning. So what it boils down to is, do I have the ability emotionally, financially, mental health wise? I mean, am I capable of providing a level of care that I want my loved one to have at home? That answer won't always be yes, and it doesn't mean anything. It doesn't mean that somebody's a good person or a bad person or a good caregiver or a bad caregiver. It just means in my circumstances, what I have to offer is not what I want my loved one to have, and so I'm going to choose placement. And I think that that's true in the midst of a pandemic or not. Again, the expectation being it's going to look a little different right now until this is reined in, but the fear of not being able to visit, caring for your loved one at home isn't going to be it's still going to take its toll. It's still going to be difficult. You're still going to be isolated at home with a loved one because you can't go anywhere.
We still have the pandemic.
You still have a pandemic.
Okay, very good. We have two more questions that I want to get to, but we're running very close on time. So
Okay.
The first one is, how do you navigate, probably how does one navigate, the process of putting a family member into a care facility right now, meaning during the pandemic?
I think in the same way. I think that you just investigate what sort of facility you're looking for, whether or not their philosophy of care is aligned with your own personal philosophy. There are agencies, referral agencies that can help you with that decision. I'm sure actually that Denise at the Alzheimer's Association or the regional managers are familiar with the different facilities and can do a care consultation with you that would help you to make an informed decision. But that's basically the bottom line, is learn about the facility and whether their philosophy of care matches yours and whether it looks like a good fit for your loved one in terms of what you want that to look like.
So folks, we do have 2 chat rooms open. I just put Denise Pottas's email on both of those as Chris referred her for care consultations. Last question here is just out of curiosity, are there facilities that provide or allow video monitoring of loved ones' room or the dining hall, etc.?
I don't know the answer to that in general. I know that our facility does not allow cameras. Part of that has to do with HIPAA, respecting people's confidentiality for being in placement. But the other part of it has to do with dignity, right? I mentioned the Ombudsman's office, and they are very much charged with maintaining a quality of life and dignity of life for people even as they age. And I think that the idea is that that is not respecting people's dignity. So we can do Zoom visits, we can coordinate FaceTime calls, but just sort of constant video monitoring is a big no-no. I don't know if that's true everywhere else, but it's certainly not something that we would do at our place for that reason.
Again, thank you, Chris. This could not be a better timed presentation. So we're very thankful for your the presentation that you provided today.
My pleasure. I will, the slides will be available. I will send those to Chris if you would like to have a copy of those, particularly for the resources. Just let him know and I'll get it to him and get those.
Thank you. I'm actually adding my email to both chats. So if you are needing those slides, just give us an email. And just one further footnote on the video cameras is that the questioner was saying, I know that parents of preschoolers have this option at daycares, but I think for the reasons that you just mentioned, it may fall into a different.
Yeah, I mean, I think that the idea is that seniors are adults and independent in a way that preschoolers are not. Again, not to minimize what it's like to be a caregiver of somebody like that and to sort of have the fears that they are at risk too. That's all valid. I get all that. And the approach is still they are not children and so they do not want to have they don't want to have their dignity compromised in that way.
Understood. I want to thank all of our participants and attendees today, and we're over time, so I'm just going to say thank you.
Thank you.
And we'll see you soon.
All right. Take care,
Bye-bye.
everybody.